Hello and welcome to Back to the Science. I'm Dr. Susan Oliver and I'm a scientist, and this is Cindy Oliver and she's a dog. So a few weeks ago, Dr. John Campbell shared a video of a consultation that he had with Dr. Aseem Malhotra, who is a cardiologist. Anyway, I was rather shocked by a number of the claims made by Dr. Malhotra because they were inconsistent with the scientific literature and treatment guidelines. But I thought maybe there's some new data that I'm not familiar with. So I checked with a few cardiologists and other doctors, and basically they confirmed that a number of Malhotra's claims definitely aren't consistent with the science. And I even got Cindy to check with a cardiologist that she knows. And he told her she was a good girl and gave her a treat. So let's go back to the science and have a look at a few of Malhotra's claims.
So I'm a bit concerned, Aseem, at the moment. I've got these blood results from my doctor.
Yeah.
And my cholesterol's a bit high. So the normal range is 2.5 to 6 and mine is 7.1.
Right.
And the doctor said I should take these.
Right.
Statin, 40 milligrams a day.
Yeah.
Now you're a consultant cardiologist. You've got a special interest in metabolic health.
Yeah.
And you've got a long history of being exonerated. We could go through the list now, maybe later. But for now, if you want to be my doctor, I would really appreciate it. Should I be taking these statins, Aseem? I really don't know what to do. I'm confused.
Yeah. So, John, very interesting. So there's two different ways of approaching this, and we'll cover both. The first thing is looking at statins in terms of their use and their benefits. And for a long time, and still a lot of people think that the benefits of statins are because of lowering cholesterol. But we know that isn't true, because I published a review in 2020 in BMJ Evidence-Based Medicine, where we showed that looking at all different cholesterol-lowering drugs, including statins, there was no clear relationship with cholesterol lowering, specifically LDL lowering, the so-called bad cholesterol, we'll get onto that, and preventing heart attacks and strokes. Statins do have a small benefit, though, through a different mechanism, John, which is they are anti-inflammatory and anti-clotting.
Okay, so straight off the bat, Dr. Malhotra is providing misinformation. There is no question that the benefits of statins are related to their cholesterol lowering effects. And I will be providing evidence of that. But firstly, let's have a look at Malhotra's review. Oh, we can't, because it's behind a paywall. But there are some interesting corrections, including the fact that they had initially tried to call it a systematic review when clearly it wasn't. Anyway, a number of experts who did have access to the paper have reviewed it. And in a nutshell, the consensus is that the paper is bollocks. And I'll provide a link that goes over in detail why the paper is bollocks if you want to read it. But what about the evidence that the benefits of statins are related to their cholesterol lowering effects and not something else? Well, before I get onto that, I'm going to slightly contradict myself. It isn't actually cholesterol levels that are related to cardiovascular disease. It's the number of cholesterol carrying particles. LDL cholesterol or non-HDL cholesterol are reasonable proxies for the number of cholesterol carrying particles. But a better one is actually apolipoprotein B. However, a lot of trials don't actually include ApoB measurements, and it's not routinely measured in general practice. So LDL cholesterol, non-HDL cholesterol, or total cholesterol to HDL cholesterol ratio are generally used in guidelines. So with that caveat in place, there are a bucket load of studies showing that statins work primarily by decreasing LDL cholesterol levels. Like, for instance, this systematic review and meta-analysis, which looked at the association between lowering LDL cholesterol and cardiovascular risk reduction amongst different therapeutic interventions. They found that regardless of the method of cholesterol lowering, the achieved absolute LDL cholesterol level was significantly associated with the absolute rate of major coronary events. And by the way, the cholesterol measurement used in this paper is millimoles per litre, which is the measurement that is used in most countries. However, if you're in the United States, the measurement used is milligrams per decilitre. To convert from millimoles per litre to milligrams per decilitre, you multiply the value in millimoles per litre by 38.67.
If you are at low risk of having a heart attack or stroke in the next 10 years, and I'm presuming your blood pressure is normal.
Yeah, normally my blood pressure is about it depends. If I take it at home when I'm relaxed, it's normally fine. It's normally about 125 over about 78-ish, something
Fine.
like that.
So it's in the normal range. You're not pre-diabetic or diabetic.
No, my HbA1c is actually okay. That's in a normal range. My long-term sugar test is normal.
Fine, great. And you're not a smoker?
Oh, heck no.
No. And John, how old are you, if you don't mind me asking?
67.
Okay, that's all very interesting. So you will be for sure, you will be in the low risk of having a heart attack or stroke in the next 10 years. Okay?
Oh, that's great, Aseem. Thanks. Yeah.
A number of factors determine someone's risk of a cardiovascular event. And Dr. Malhotra failed to ask John about a number of them before pronouncing him low risk. The risk calculator that is used in the UK is this one here, which is called Qrisk 3. As you can see, amongst the questions that Malhotra didn't ask before making his pronouncement was whether there was any family history of cardiovascular events, whether he suffered from a number of different health conditions like erectile dysfunction, although I can understand why you wouldn't want to ask that question when there's potentially millions of people listening. He also didn't ask what his HDL cholesterol level was, although he did ask that question later, so we have it to use in the calculator. And he also didn't ask what his height and weight were, even though John is clearly a bit overweight. And although he did ask him about his blood pressure, he didn't ask if he was on blood pressure medication, which makes a difference. And that is also something that we do know.
My blood pressure strangely went up in 2020. So it had been low all my life. Then all of a sudden, 2020, I checked it and it had gone up. Strange but true. So I assessed that I had high blood pressure. My diastolic blood pressure especially was a bit high. So the plan was I take some blood pressure medication. I take some amlodipine. The implementation is I take that and I assess my blood pressure from time to time. And yes, thankfully, the amlodipine is keeping my blood pressure under control.
Anyway, if we put in the available information for John and assume that the answers to all the other questions is no, and allow the calculator to estimate information that isn't available, like BMI, we see that John's risk of having a heart attack or stroke in the next 10 years is over 20%. This is not low risk. According to the guidelines, if your risk is above 10% and attempts to lower your cholesterol levels with lifestyle modifications have failed, a statin should be considered. And just in case you're thinking the calculator is designed by Big Pharma and everyone comes out high risk and needing a statin, I put my details in and I ended up with a risk of 2.8%, which means I shouldn't be prescribed a statin. And I haven't been. And the postcode that I put in was actually the postcode where I was born, which strangely was actually in the town where Dr. Malhotra's parents practiced as GPs. One more thing worth mentioning is that it is not clear whether John's cholesterol levels were without a statin or were with a low-dose statin, as he has previously stated that he has been taking a statin since 2016.
And then other medical history. So at the time I was taking a atorvastatin for cholesterol, and to put that in.
If he was already on a lower dose statin when his cholesterol levels were measured, his cholesterol and therefore his cardiovascular risk could end up even higher if he stopped the statin altogether.
And what that means is, John, that your benefit of a statin at best over a 5-year period, at best, because this information is curated by the drug industry, it gives you a 1% chance of a statin, if you took it religiously, preventing you from having a heart attack or stroke, but without prolonging your life by 1 day. That's if you don't get side effects. So, John, I've given you that information as it is. If I told you that there's a 1% chance it will benefit you if you don't get side effects, is that a drug you'd like to take?
Well, it's not going to increase my chances of living longer, which is really the one of the key indicators. Sure. I've got so much left to do. So if it's going to reduce my chances of a heart attack by 1% if I take this every day for the next 5 years, but make no difference unto my life expectancy, then I think I might leave that one actually for now.
Listen, John, your reaction is not unusual. In fact, they've done studies that, given that information presented in a transparent, honest way, most patients with a 1% benefit wouldn't take the pill. So you're not unusual at all. And I support your decision in keeping with what we call the principles of ethical evidence-based medical practice.
So there's a couple of things to note here. Firstly, when Malhotra says 1% benefit, he is talking absolute benefit. So he is saying if John doesn't take a statin, he has an extra 1 in 100 chance of having a heart attack or stroke in the next 5 years. But that is based on him being at a low risk of a heart attack, which he isn't. This review here provides a rather different value. They state a typical absolute benefit of 5% over 5 years for patients at increased risk who haven't already had a vascular event if LDL cholesterol is lowered by 2 millimoles per litre. That means if you choose not to take a statin, you have a 1 in 20 extra risk of having a heart attack or stroke over the next 5 years. But that's only half the story, because most people are planning to live longer than 5 years. It's like if you were a smoker in your 30s, giving up smoking probably wouldn't provide much health benefit in the next 5 years, but it would over your lifetime. And it's the same with cholesterol lowering. The benefits accumulate over time. In this systematic review and meta-analysis, they looked at the benefits of cholesterol lowering therapy over longer time periods. And what they found was that the longer cholesterol was lowered for, the greater the reduction in risk of cardiovascular events. So whereas the reduction per millimole per litre lowered was about 20% at 5 years, it was about 50% at 40 years. And I haven't got enough fingers and toes to show you that. So 40 years. And this is a relative reduction in this case, not the absolute reduction that we were talking about earlier.
Your LDL, what's your LDL at?
Well, my LDL, low density lipoprotein, was, it says serum LDL 4.3.
Okay, so LDL is the one where you often patients get a red flag if it's above 3 millimoles from their GP. But what's really interesting is if you're over 60, all right, I found through research published in BMJ Open in 2016 with a number of international scientists, if you're over 61, there is no association with LDL cholesterol and heart disease. So LDL does not have any association with developing heart disease in the future. And the other interesting finding, John, was there was an inverse association with LDL and all-cause mortality. In other words, the higher your LDL statistically, if you're over 60, the less likely you are to die, probably because cholesterol has a very important role in the immune system. And older people are more vulnerable to getting infections and dying from infections. So there is nothing to worry about. So I'm absolutely would advise you that there is no reason for you to lower your LDL at all, because we know it doesn't prevent heart attacks and strokes on its own, and actually it may be protecting you. So I would leave your LDL as it is.
The study that Malhotra is talking about here is yet another study he has authored that has been widely criticised by experts in the field. Particularly telling is the fact that Malhotra and his co-authors ignored all the randomised controlled trials that clearly show that lowering LDL cholesterol levels reduces cardiovascular events in people of all ages, and instead just looked at cohort studies. They even ignored the fact that one of the studies that they included clearly showed that taking statins provided a survival benefit. But what about the claim that low cholesterol levels are correlated with increased mortality? The first thing to know is that this isn't the case with randomised controlled trials. In RCTs involving cholesterol-lowering medications, lower cholesterol levels are correlated with decreased mortality. But it can be seen in observational studies, and the reason is believed to be reverse causation. A number of conditions that are linked to increased mortality are known to decrease cholesterol levels. So the low cholesterol levels are caused by the disease that leads to mortality, but there is no direct link with the low cholesterol levels and mortality. A similar thing is seen with body weight. It is well known that obesity is linked to increased mortality, but a link is also seen with low body weight because a number of serious conditions can cause you to lose body weight.
And of course, John, as you know, I've been involved in this sort of controversy over statins going back till 2013 when I published in the BMJ, and then carried on publishing stuff, even though we got pushback and threats of retraction and going on trial and winning all of that stuff. And only a couple of days ago, the Mail on Sunday lost a case that was brought against them for libel from Zoe Harcombe and Malcolm Kendrick. I was one of the people named in this very defamatory article saying a place belongs in hell for doctors to say statins don't work. And the case was won. Yeah, the case was won. I didn't sue. My mum had just died. I thought it wasn't worth me doing that. I carried the campaign on statins, which I have been doing. Malcolm and Zoe obviously weren't allowed to speak about it, but I'm at least allowed to carry on talking about that. But unfortunately, it is what it is. I lost my NHS job because of it. I wasn't allowed back in the NHS. I was getting smeared on social media purely based upon the fact that I lost my job because of the statin stuff, which we've now been exonerated from.
Okay, so this is the apology that the Mail on Sunday had to write as a result of the court case. I will just read you out some of what it says. At trial, the court held that our articles had accused Dr. Harcombe and Dr. Kendrick of knowingly making false statements about statins, and that a very large number of people ceased to take statin medication and were exposed to serious risk of heart attack or stroke on a scale worse than the MMR vaccine scandal as a result of those false statements. The articles also alleged that there were strong grounds to suspect Dr. Harcombe and Dr. Kendrick of making these statements, motivated by the hope that they would benefit materially, and included quotes from the then Secretary Matt Hancock, which suggested that their statements were pernicious lies. We accept the findings of the court that the inclusion of the Hancock quote created a misleading impression of what he said. We also accept that these allegations are untrue and ought not to have been published. Now let's talk about what it doesn't say. It doesn't say that the statements made by Dr. Harcombe and Dr. Hendrick about statins were correct, just that they weren't knowingly making false statements, which is not the same thing. So Dr. Malhotra has not been exonerated. The Mail on Sunday also claimed that Harcombe and Kendrick were responsible for people discontinuing statins and therefore exposing people to a serious risk of heart attack or stroke. Now, there is in fact evidence that negative statin stories do result in people discontinuing statins, and that this results in increases in myocardial infarction and cardiovascular mortality. But clearly the Mail on Sunday article went too far in its accusations. Again, this does not exonerate Dr. Malhotra. It just shows that newspapers like to sensationalise stories and print information that goes beyond the available facts. So, in summary, Dr. Campbell should get a second opinion. If you'd like to look further into the data I've presented, I provided links in the video's description. And please remember, this video is about the science, but you shouldn't take it as medical advice. For that, you should speak to your medical practitioner. If you've got this far, thank you for listening. And if you've liked, shared, or commented on the video, double thank you, because that helps the algorithm and means that more people will see the video. And of course, thank you to everyone who has bought me a coffee or little Cindy here a treat. We really appreciate your support. We will be continuing to make videos about the science in the future. So if you'd like to join the cool kids and stay informed, please hit the subscribe button. Thank you.